boy, we have several questions. I think we can start with you, Sanjay. Maybe we can go to question number 3. When would you use a bare metal stent versus DES?
Excellent question. When do you use a bare metal stent versus DES? So there's been, stents have evolved, come from the palmar shot stent, then the bare metal stent, then the drug-eluting stent, now the bioabsorbable stent. There's a few times that we have to use bare metal stents compared to drug-eluting stents. And both in my personal practice and also ACC guidelines, this is the thing. Number one, you ask the patient if they can take dual antiplatelet therapy. So that's the paramount. What do you mean by dual antiplatelet therapy? Well, the duration of medication for stents varies depending upon the kind of stent it is. So if it's a bare metal stent, you aspirin 325 followed by 81 for life and Plavix for 6 months versus Plavix for 1 year for drug-eluting stents. So if someone says that they cannot take a dual antiplatelet therapy, may it be Efi and ticagrelor or Plavix, then there's your answer. You have to respect that and use a bare metal stent because a stent, the chance of restenosis would be much higher or thrombosis. If someone is having a planned surgery in 6 months and they cannot put it off, and they say, you know what, I'm not going to be able to put off my liver resection after 6 months. If you use a drug-eluting stent in someone like that, you're kind of caught between a rock and a hard place. So it's better to use a bare metal stent, with the caveat that both your target revascularization, your restenosis, rethrombosis rates are slightly higher with bare metal stents. Now, having said that, there's new guidelines that are going to come out sooner about the duration of dual antiplatelet therapy. So,
okay, great. Mahesh, can you help us answer this question? How do you decide between bypass or stenting when someone has many blockages?
How many days do we have to discuss this?
I had to kind of stand up and stop you before you talk too much about bypass surgery. I don't know if you noticed that, but please go ahead.
Well, I mean, first of all, it's important to realize that we have guidelines now that are based in fairly good evidence, not perfect, but fairly good evidence. And every year, as the trials, as we have more trials that release data, we have a stronger basis for making the decision. So I would say that probably in 3/4 of our patients, based on the guidelines that we have from trials, or based on symptoms and complexity of disease, we can make a fairly good informed decision as to whether the patient would be better off with bypass surgery versus stenting. Now, factors that will come into play would be, whether or not the patient's a diabetic, the syntax score or the overall complexity of the disease, the way the patient presents, acute MI versus stable coronary artery disease, et cetera, et cetera. But there is, I think, a good number of patients, 1/4, maybe 1/3 of our patients, in whom it's sort of gray, and where either or neither, perhaps, is a good option. And this is where the value of a heart team really comes into play.
Indeed.
And I think the key thing when you have a heart team, and every other week, every other Friday, we have an ischemic heart disease conference here, which is well attended by our cardiologists and fellows, et cetera. When you have this sort of discussion at your institution, the first step that you have to take in your mind is to understand that the other person has a legitimate point of view. That's the first step. You have to respect each other and understand that person has a legitimate point of view, or put another way, yours is not the only legitimate point of view. And this is actually saying quite a bit because, it's all of us have, colleagues that believe strongly in what they do, and by extension almost think that that's the only way to do it. But I think if you take that sort of open-minded approach, you will discover that just thrashing things out amongst yourselves allows you to come to a reasonable, not perfect, but reasonable decision for that remaining 1/3 of patients.
Indeed. And just to add to that, I'd like to plug in a clinic actually which Dr. Ramchandani has initiated on the Smith Tower on the 14th floor. It's called Advanced Complex Ischemia Clinic. See, for patients just like this, where there is a real need for a heart team approach, the surgeons and the interventional cardiologists get together and get to see the same patient, give him or her their benefits, options, and so on and so forth. So heart team approach is so vital to that concept. Sanjay, can you look into answering maybe what type of stent are used in acute MI?
So, still, the guidelines suggest using drug-eluting stent. There was some brief noise, I would say, about using bare metal stents in acute MI, but it has not changed. So, drug-eluting stents are still the current recommendation and choice in acute MI. Again, you have to take a minute and also ask the patient if they would be able to tolerate or continue with dual antiplatelet therapy, or you have to look at the situation. Sometimes we are faced with situations where a patient comes in and is having an acute MI, but he's also having a GI bleed, and that's not uncommon. And it takes very little time to put in a stent, but it takes forever to talk to the gastroenterologist and say you can't stop because next morning the patient will be having an EGD. So, right, but the benefit of stent thrombosis is still much, much different, and risk of stent thrombosis is much higher with bare metal stents than drug-eluting stents. So, current guidelines still.
So let me see if we can get to two quick answers. Mahesh, if you can, what is the lifespan of a graft and what are the revascularization options for stenosis of a graft?
So there are basically two broad types of grafts. You have saphenous vein grafts and you have arterial grafts. Saphenous vein grafts have been shown in a variety of studies to have a one-year patency rate of anywhere between 75 and 90%, not quite, and this is one-year patency. We know that after that, the attrition rate for a saphenous vein graft is roughly 1 to 2% per year. So at 5 years, you're going to have about, 70% patency for a saphenous vein graft, with so 2/3 are patent and 1/3 would fail. Arterial grafts, on the other hand, the left internal mammary artery or the right internal mammary artery, either mammary artery graft, has been shown to have a 97% patency going out to 10 years. Most of the failures which occur in these grafts occur early on as a result of technical issues or as a result of severe distal disease that the patient might have. If the graft stays open, if an arterial graft stays open in the early phase, it is likely to stay open for the lifespan of the patient. And that's an important difference. Now, the radial artery is another arterial graft that is used, and the patency rates for the radial artery are somewhere less than the internal mammary artery, but definitely much more than a saphenous vein graft. And the reason is the radial artery has a very thick muscular media which is prone to spasm. And so patients who have radial artery grafts should be on some sort of antispasmodic, usually a calcium channel blocker, for at least 6 months or maybe up to a year after they've had the graft initially placed.
Right. I'll just give quick two answers because we are over time. Does atherectomy increase the risk of stroke? No. For the previous speaker regarding P2Y12, when one gets the bare metal stent, how long do you use Plavix or other NOACs? I'm assuming this patient requires a NOAC for possibly AFib. Then it's usually 1 month of aspirin, Plavix, and NOAC. After 1 month, we stop aspirin and Plavix both. If this is done for ischemic heart disease, not for ACS. If it's ACS, then the person requires Plavix for 1 year. Thank you very much.